I'll just give you a brief introduction to Simon. Simon's Cardiothoracic Senior Registrar down in Papworth, and he's been instrumental on the DCD Heart programme with his PhD over the last 3 or 4 years with Mr. Stephen Large. And so this is it's been a big step. Basically, up to 3 years ago, there was no DCD non-beating donors, and Simon's just going to give us an overview. And Papworth now is the biggest series in the world of DCD heart transplantation, and I'll let him tell us all about it.
Okay, thank you for the invite. Thank you, Phil. It's a pleasure to be here in Glasgow to give you an update on DCD heart transplantation. And I'm here really to help you guys get DCD heart transplantation up in Glasgow, because I think it'll help you a great deal. So the topic was DCD heart transplantation, the new frontier. This was the title of my talk that was given to me. So to answer that, I'd like to give you a quick update on the state of heart transplantation within the UK and see why we've got some problems. Then we'll talk about what DCD stands for and what is DCD heart transplantation. What's the potential of DCD heart transplantation? Can it help us? What's the different methods of DCD heart retrieval? And how do the results of DCD heart retrieval compare with the standard of DBD, donation after brain death heart transplantation, the standard that we use day in, day out? So this is the NHSBT slide. This is this is a heart transplant waiting list over the last 10 years. And you can see here it's increased dramatically. So the demand for heart transplantation has increased by 162% over the last 10 years. So this is a big problem. So what happens to patients on the elective heart transplant waiting list, or the non-urgent? So when I came to Papworth, I thought they actually got transplanted. And unfortunately, I was sadly mistaken. Only 23% are transplanted after 3 years. 14% deteriorate and die. 14% become too sick to be transplanted, and they're taken off the waiting list. And this 39, almost 40%, move and are admitted to hospital for urgent listing or super urgent listing. Now this is a huge financial cost to the NHS. Patients get admitted to HDU or ITU, get balloon pumps inserted, central lines, inotropic support seen by physicians day in and day out. This is a huge financial cost. And ultimately only 23% are transplanted. So there's a big problem. We don't have enough donors and an increasing heart transplant waiting list. So what's the difference between donation after brain death and donation after circulatory death? A donation after brain death, just to any layman in the audience, donation after brain death, catastrophic brain injury, admitted to hospital, you're still on a ventilator, your heart's still beating, and as heart surgeons we will assess the heart with a Swan-Ganz catheter, and you also get an echo, and as well as the surgeon palpating the heart, see if there's any coronary artery disease, and we will only take excellent hearts, ones that have got ejection fraction greater than 50%, and generally a cardiac index greater than 2.5 litres per minute per metre squared, with filling pressures less than 12. So they will be pretty excellent donor hearts. Donation after circulatory death. So these are donors who have had catastrophic brain injury, but they won't have, but they'll have some sort of brainstem reflex, maybe a coronal reflex, some triggering in a ventilator. They're not suitable for brainstem testing, or the family don't want them to go down this route. This happens now and again as well. So the heart has the withdrawal. They take the extubate, stop the inotropes, and the patient will become hypoxic, then will become hypotensive, then they become asystolic, and in the UK we wait another 5 minutes following asystolic, and then they're declared dead. And then it's the paraphernalia, getting patient sort of draped and so on and so forth through to theta, and at that moment we can start retrieving the heart. So the big difference is you're going to have a warm ischemic time in the region of 30 minutes for DCD. And for the last 35 years we thought that 30 minutes would be catastrophic to heart function, not suitable for transplantation, and therefore we've completely ignored DCD donors for that reason. Other organs have cottoned on to DCD a lot sooner than us. So if you look at this slide from NHSBT, you can see that DBD donors in light blue here has plateaued. Okay, so it's a fixed amount of DBD donors. But year on year, the number of DCD donors has increased in the UK. So DCD has been a huge success for the UK. So donation's gone from 1.1 to 18.3 donors per million population for DCD. Kidney transplantation's been a massive stakeholder in DCD, and they've gone from 1.9 transplants to 11.7 transplants per million population using DCD. Liver transplantation, DCD constitutes a quarter of the national liver transplant program using DCD. And I'm sure Professor Dart will tell us more about DCD lung transplantation and equivalent outcomes to DBD transplants later on today. So what's the potential for DCD heart transplantation in the UK if it was possible? So we took the national DCD database and looked at it from 2011 to 2016. We then screened these donors and excluded those with no consent, those that we thought would not be suitable because of age, so excluded those that were less than 50 years old, and those that had a functional warm ischemic time of less than 30 minutes. So functional warm ischemic time is from systolic less than 50 in the donor to the onset of blood reperfusion. And then we whittled them out as you would a cardiac cause of death, so you don't want any ischemic MIs, inotrope dependent, so we probably wouldn't take a DCD heart that was on adrenaline or dobutamine or dopamine, anything that had past cardiothoracic disease, diabetes, hypertension, and that left us with 555 potential DCD heart donors over that 6-year period. So that works out as 93 DCD hearts per year. And in that period, we did almost 1,000 DBD heart transplants. So DCD represents 8.6% of all potential DCD organs that are offered. This is quite a lot, actually, considering we offer up to 80 years old for DCD organs. And DCD heart transplantation has the potential to increase heart transplant activity by 56% in the UK, and that's using donors less than 50 years old. So if we go up to 55 years, it would increase it by 71%. And if we went up to 60 years old, it's got the potential of increasing it by 81%. Now, lots of people sitting in the audience go, that's ridiculous. But there's lots of things that can help with DCD. So organs can be assessed. Once we put them on organ perfusion, we can do angiograms. We can do NRP to assess hearts in the donor. So these numbers actually are not that far off. So what you need to know is it could increase it by 50% at least. There's 3 techniques of DCD heart retrieval in the UK. One is direct procurement and perfusion. And this is where we take this asystolic heart directly out of the donor and reperfuse it or reanimate it on an ex situ perfusion device. So it's basically a miniature cardiopulmonary bypass circuit that's portable, and we perfuse the heart in Langendorf. So we can perfuse the coronary arteries so the heart's beating, but not pumping. Then there's something called normothermic regional perfusion. And normothermic regional perfusion is following declaration of death. We open the donor, we clamp off the arch vessels, we put an aortic pipe, a venous pipe, and we reperfuse the heart within the donor, allowing a functional assessment. Now, in the majority of cases, we'll follow that up by continuous perfusion during transportation, minimising the ischemia time. However, we've also done it with NRP and followed it by cold storage, where the donor and the recipient are in the same hospital. So a little bit more on those techniques. This is direct procurement and perfusion. So the heart's been taken out, we've used donor blood, and this is the heart on the only machine we can use in town at the moment, called the organ care system. And the heart's beating, but it's not pumping. Okay. Now the advantages are, it's pretty simple to perform. You just take the heart out, put it on the machine. There's no additional blood products because we're using donor blood. You don't need any additional staff, such as a perfusionist to go with you. I know that's a little bit controversial, but we use donor care physiologists to help us and transplant practitioners. You don't need any additional equipment. You don't need any extra pumps, and it's easy to teach the others. So we've proctored Manchester through it, and also helping Newcastle to go through it as well. The drawbacks, and it shouldn't be underestimated, but the biggest drawback is you're unable to functionally assess the heart. So I'm sure everyone can tell you has heart failure, and there's certainly somebody that's sitting in the audience who's had a heart transplant and lived with heart failure. Just because the heart's beating doesn't mean it's pumping, okay? Because these hearts aren't pumping, you can't functionally assess the heart. And this is a big problem with direct procurement. Because the heart's been without a blood supply for 30 minutes, and this is what sort of held us back for the last 35 years. Every heart we put on that machine costs us €35,000 for every heart we've declined if the company don't refund it for us. So it's sort of the company's whim. Okay? And we're reliant on lactate. And I've got to say, you're reliant for DCD heart transplantation, and the lactate story is that lactate is useless. If we turn down hearts based on lactate not going down, or if it's actually increasing, then we do a fraction of the number of DCD heart transplants we do. So that's the direct procurement and perfusion. The next strategy is normothermic regional perfusion. And this is for the donors brought into theatre following declaration of death. We do a median stenotomy. We clamp off the arch vessels, and we also staple get these arch vessels off now as well. And then put an aortic pipe in, a venous pipe on, and we'll go on NRP, normothermic regional perfusion. And we'll do a carotid to ensure there's no cerebral circulation. Then intubate and ventilate these donors, and then wean them from NRP. And that allows us to put a Swan-Ganz catheter in, and a transesophageal echo, and we can full functionally assess these hearts. So once we've fully functionally assessed these hearts, we give cardioplegia to the heart and put it on the perfusion platform that I've just shown you. And that's the organ care system from TransMedics. And then we bring that heart back and transplant it. This is the procedure. So this is a clamp across the arch vessels, aortic pipe in here, venous pipe in here. And this is us coming off NRP. This is the heart taking over the circulation with the PA trace and arterial trace. And this is the 4-chamber transesophageal echo. And this is the heart on the OCS, ready to be transplanted. And you can do an angiogram on that. In fact, you've done an angiogram up here on the OCS. Okay, so the advantages of NRP is allows a full functional assessment of the heart, so you can take anything and you can just transplant, you can try it out and see what the parameters are like. And that's certainly, we've had very risky donors that we've felt reassured following functional assessment. So we went up to 57 years old and an ischemic time of over 2.5 hours. It's quicker to reperfuse the heart using that technique than taking the heart out and putting it on the machine. So if you just put 2 pipes in and go on bypass, essentially, it's much quicker by about 7 minutes than taking the heart out and put it on the organ care system. We don't rely on lactate. That's one of the benefits of NRP, and allows the donor age to be extended. So we went up to 57 years old, and there's no reason that we can't go any further than that. We could go up to 60 and do a coronary angiogram on the machine. It also avoids the cost of placing a heart on the organ perfusion platform, the OCS. And for every heart, if we turn down a heart on the OCS because it's we deem it not suitable, or the lactate goes up, because we put it on NRP and we've had a functional assessment, then we would feel reassured and less likely to turn it down. Also allows the liver, kidneys and lungs and pancreas to be perfused, and removes the haste. It definitely removes the haste from organ retrieval and the subsequently organ injury that's associated with that. The drawbacks are it's an additional cost of €3,000 for the NRP pump. There are ethical concerns of perfusing cadaver in other countries, so this won't happen in the States. They won't do this in the States, but it will happen in Canada. It has happened in Belgium. They transplanted 2 DCD hearts 3 months ago using this technique. There's additional blood products used in theatre, additional manpower. It takes a little bit longer in a donor hospital, and you've got to keep the skills and training to keep your NRP program up and going. You've also got to work in collaboration with the abdominal retrieval team, which can be a positive and a negative. Okay, it can be quite difficult sometimes working with the abdominal retrieval team when you're doing NRP. So now I want to show you what's the results of DCD heart transplantation compared to DBD heart transplantation. So if the results are inferior, there's no point in even beginning a program here. So we published these outcomes in the Journal of Heart and Lung. This was December last year. We've done 51 DCD heart transplants up until now, we started on the 1st of March 2015. These results go up to the March 2018. Okay, but we've done 51 because we just did one about 2 weeks ago. The primary outcome in our study was the 90-day survival. The secondary outcomes were the things you'd be interested in as intensivists, surgeons, physicians. How much mechanical support do we need? Inotropic support post-transplant. How well does the heart perform when you shoot your first cardiac output in intensive care? How long are the patient in intensive care for? How long are they on the ventilator for? How much hemofiltration do they require? How long are they in hospital for? And the rejection episodes. So we we're reliant on category 3 DCD donors. Okay, so these are the ones that are stable, DCD donors, and it's planned withdrawal. Donors were from 18 to 57 years old. Our noradrenaline requirement prior to withdrawal, we didn't go any higher than 0.3 mics per kilo per minute. Just to put that in perspective, is we won't touch a heart in Papworth if they're on greater than 0.07 mics per kilo per minute for a DBD donor. And our echo requirement prior to withdrawal was an ejection fraction greater than 50%. So the results, we attended 63 potential DCD donors, so we went on 63 runs. 9 failed to arrest within 4 hours. So if they hadn't arrested within 4 hours, we went home. So that left us with 54 hearts that were retrieved, and 22 went on normothermic regional perfusion. And of those 22, 5 were declined for 3 had palpable coronary disease, so we didn't put these on the transmedics or do any angiograms at that time. And 2 had poor function, so we turned them down. 16 of those hearts then went on NRP, or went on the transmedics, and then 1 we did on cold storage. And that's when we had the donor and recipient in the same hospital. So that was a situation where the donor was on VD ECMO, had a massive intracerebral hemorrhage, and they couldn't brainstem test him because he was on huge doses of thiopentone. So he went under DCD, and we did exactly how, or very similar to how the first heart transplant was done by Christian Barnard in '67, with the donor and recipient in co-located theatres. That left us with 17 NRP hearts that were transplanted. We had 32 direct procurement hearts. 32 hearts went on the OCS, and 5 were declined on the OCS. 1 was for a rapidly rising lactate, and that's when we didn't have much we didn't have much experience, so we had to go by lactate. 1 was turned down for malignancy. Once we were on the way home, the abdominal surgeons said there's a pancreatic tumour that they subsequently diagnosed in a donor. 1 had coronary artery disease that we had shot in the angiogram, and 2 had left ventricular hypertrophy that was undetected on the echo prior to withdrawing. That left us with 27 direct procurement hearts. So there was 44 DCD heart transplants in total. I'm sorry, the data's a little bit dry, but if you look into it, so in the left-hand side here, we've got our 2 groups, which is DCD versus our matched cohort of DBD heart transplants in Papworth. So same time period, so same era, same surgeons, same physicians. And then we compared NRP with direct procurement, so the 17 NRP versus the 27 direct procurement. So these are our donor demographics, and you can see that the DCD and DBD are well matched, as you'd expect. It's impossible to match for cause of death, and the reason for that is there are more patients with hypoxic brain injury in the DCD group because they won't go on to have brainstem swelling, subsequent coning, and go on to be brain dead. So you will have, whatever way you try to do it, you will always have more hypoxic brain injury in the DCD group. And also in the DBD group, you also have more intracerebral hemorrhages because they will go on to cone. So that you can't, unfortunately, adjust for that. When we look at NRP versus direct procurement, there's a difference as well in cause of death, and that's because our major tertiary neurosurgical centre is the one where we did NRP, so subsequently there'll be more intracerebral hemorrhages in there. If we look at the recipient demographics, there's no difference in comparing DCD and DBD, no difference in age, sex, height. And initially, if you want to do DCD heart transplantation, I'd probably go for a TPG less than 12 and pulmonary vascular resistance less than 3 Wood units at the start of our programme. If we look at the difference between NRP and direct procurement, there's no difference in recipients either. There is a difference in NRP versus direct procurement in pre-transplant mechanical support. So at the beginning of our program, we launched it with NRP because we had the full assessment of doing the hearts with a quality check, which was the functional assessment. Our program took off, and we realised that if the functional warm ischemic time was less than 30 minutes, we didn't really have to assess the hearts. And as our program took off, we started looking into more challenging cases, and Professor Milano's already hinted at doing a VAD explant, far more tricky transplant than doing a virgin chest. So as time went on, we had more patients in the direct procurement group that had ventricular assist devices, because we did all our easy transplants at the start using NRP when we were learning technique. There's no difference in the matched cohort though. And you can see the majority of patients have dilated cardiomyopathy in our groups. There's a difference in ischemic timings when you compare NRP and direct procurement. So how much ischemia does the heart have to tolerate is a very important question. So the withdrawal, turning the ventilator off to the declaration of death, there's no difference in the TVT groups between NRP and direct procurement. Donation withdrawal ischemic time. This is turning the ventilator off to the heart being reperfused by blood in some way, shape or form. So in NRP, it took us 24 minutes to get the heart reperfused, and direct procurement is 36 minutes. You have to watch that because that will make a difference over 30 minutes. And as you can see, it's a significant p-value. The functional warm ischemic time is this systolic blood pressure less than 50 in the donor to the heart getting reperfused, because most people begin to think that under 50, the heart will suffer in terms of perfusion or malperfusion. And you can see that there's a 7-minute difference between the functional ischemic time in NRP versus direct procurement. There was a longer time on the OCS between NRP and direct procurement because our NRP centres was where we did our research initially, and they were all based around Cambridge. As we took on more centres wanting to refer DCD hearts for us, we travelled into further and further. However, NHSBT were quite reluctant to let us do NRP in these small district general hospitals. So we went with direct procurement, and as you're coming back from, I don't know, Brighton all the way back to Papworth, it'll take you 2 hours to get home. Implant duration. There is a difference, again, between NRP. This is where the consultant surgeons initially started, because NRP was where we began. So the consultant surgeons were quicker. And then moving on to when it was a free-for-all for all the implanting surgeons and the registrars. So obviously the registrars are going to be slower. So that's why that is longer. So if we look at our outcomes, first one we'll look at is 30-day survival. So when we come look at the main thing of this slide is DCD versus DBD, okay? So the 30-day survival is 100% in both groups, DCD and DBD. The 90-day survival is 93% in the DCD group and 95% in the DBD group. So 2 patients died of primary graft failure in our DCD group. One was a patient of VAD explant, and one patient was a salvage attempt at transplant. She was on ECMO support following a cardiac arrest in the intensive care unit. And she subsequently had another DBD transplant, retransplant, but unfortunately that failed as well. And our third patient went home on day, I think it was 25, and then was readmitted for fungal sepsis. There was 2 deaths in the DBD group, both from primary graft failure, and subsequently required ECMO support and multi-organ failure. When we look at mechanical support post-DCD transplant, it's about 20% require intra-aortic balloon pumps, and then 20% require intra-aortic balloon pumps in our DBD group. Almost 10%, 11% required ECMO in our DC group post-transplant versus 7% in our DBD group. And these ECMO, 2 developed, we went on to put VADs, and unfortunately they both died. And again, put a patient on a VAD in the DB group, and they also died. When we compare NRP versus direct procurement, there doesn't seem to be any difference when we look at 90-day survival. All our deaths have been in the direct procurement group. However, it's not reached statistical significance as yet. You have to bear in mind that more patients had mechanical support prior to transplantation in the direct procurement group. If we look at inotropic support in the intensive care, when we look at DCD versus DBD, we'll usually come off in Papworth of cardiopulmonary bypass after transplant on dopamine at 5 mics and adrenaline at 0.05, and that's exactly the same for DCD and DBD. There's no statistical significance. When we look at NRP versus direct procurement, again, there's no difference in terms of how much inotropic pharmacological support is required post-transplant. This was very interesting, though. Cardiac performance post-transplant. So this is the first cardiac index when the patient came back to intensive care. And this is... So when I'm on call for transplantation, this is a workout if I'm going to get any sleep that night by how good this cardiac index is. So a cardiac index of 2/2, I think that would be fine. Anything under that, then we're going to be up all night at the bedside for this patient. So for DCD, it was 2.4, the cardiac index, the first cardiac index we shot. And for DBD, it was 2. and it's just getting on statistical significance there. And cardiac output was significant. It was 4.5 versus 3.9. And you can also see reflected in the mean arterial pressure when that was recorded as well. There's no difference between NRP and direct procurement in terms of pharmacological support or the cardiac index that was shot. So when we look at other outcomes, how long were they on the ventilator for? The DCD group, over 1.1 day versus 1.8 days in the DBD group, but there's no significance. Hemofiltration, about 40% of the DCD group required hemofiltration, but there was no statistical significance between that and DBD. Intensive care stay, our DCD patients required 5 days in intensive care stay, medium, and also for DBD was 7. So our shortest DCD heart transplant has stayed 1 day in intensive care, which I think is incredible to date. We've also seen that for DBD, but people told me this would never happen, which is a testament to the programme. In terms of hospital duration, patients spent 20 days in hospital following their transplant with the DCD group and 27 days post-transplant in the DBD group. There's no difference in rejection. In terms of NRP, there is more hemofiltration in the direct procurement group, and this is because of, I think it's a reflection on the mechanical support. More patients were on left ventricular assist devices pre-transplant. This is also reflected in intensive care stay. This is the Kaplan-Meier survival curve for those patients. 1 year survival, DCD in red, DBD is in black here. So as a reflection, this is a NHS BT slide from 2017 to March 2018, and this shows you each unit's heart transplant activity. And you can see in dark blue here is DBD, and then light sort of blue is DCD. So DCD increased our heart transplant activity that year by 40%. What else does it allow? So all those patients they would have been bridged to heart transplantation through an urgent waiting list or require urgent listing or super urgent listing. These patients this reflects the non-urgent patients who are transplanted. So we've massively increased the patients who are transplanted from the non-urgent heart transplant waiting list, saving the NHS a small fortune. So is DCD heart transplantation possible in Glasgow? Well, because we do DCD lung transplantation in Papworth, then I get to see all the DCD offers throughout the UK. So we had this offer last week for a DCD lung. They won't allow us to retrieve anywhere else apart from that. They've got a selected retrieval zone in the south east England, Midlands, and around Manchester zone, but they won't allow us any further as yet. However, I noticed in maybe not 50 minutes from this hospital, there was a DCD donor last week from a 19-year-old male, A positive, 176 centimetres, 69 kilos, no relevant past medical history, and an intracerebral hemorrhage following trauma. So I suspect you probably have someone who that would be suitable for. So that heart got wasted. So, conclusion. DCD heart transplantation has the potential to increase overall heart transplant activity by 56%, and the early outcomes of DCD heart transplantation are at least equivalent to that of DBD heart transplants. And I'm going to stop talking and leave you with this video for a second. Okay, this is our second DCD heart transplant, and this was...
I like being outdoors. I like motocross, the adrenaline, the speed. I like things that get the heart moving and going as such.
Tom Shing was an active, healthy teenager.
I was playing football once a week, wakeboarding the weekend, never smoked, I didn't really drink.
But aged only 19, his life was suddenly turned upside down.
I used to struggle with getting dizzy and breathing. I'd throw up. Took me 5 attempts just to get out the underground. Could do 2 stairs at a time. I would almost black out.
Tom was diagnosed with cardiomyopathy, a disease of the heart muscle. 14 years before, the same condition had killed his mum, leaving a 5-year-old Tom in the care of his grandparents.
She was sitting at the computer doing some work, and suddenly she passed out.
Tom was referred to the Royal Papworth Hospital in Cambridge, renowned around the world for pioneering the UK's first ever heart transplant. Tom spent 2 years on the waiting list for a new heart, and time was running out.
Every day I'd wait for the phone call. I never knew whether a heart was ever going to come up. I was getting weaker and weaker. I ended up going to the stage where I had to go and live in hospital and wait.
It was not until then that we realised that he was deteriorating. He was fragile. We just was sit and worry every day.
There was no ifs or buts. I would get to a point where I need the transplant or I die.
Hearts to be donated through donation after circulatory death. It means the Stephens have increased the number of available hearts by 35%.
It was a relief to me that I woke up and felt so well. If it wasn't for the team and all the pioneering work that they're doing, I wouldn't be alive today. 10 weeks after the op, I was back to wakeboarding and back to my motocross 12 weeks after. Mum would be proud, considering all the stuff that's been thrown at me.
Okay, so that's Tom. He's 24 when he's transplanted. He was our second DCD heart transplant recipient. And he is an ambassador for DCD heart transplantation for us. He's just come back from Canada, trying to get Canada on board for DCD heart transplantation. And he's going to join me in Wales next month to try and get Wales donating DCD hearts as well. And they're particularly interesting for the opt-out reason. So this is 3 years of DCD heart transplantation. That's what it looks like. That guy is fitter than me by a long shot.